So good afternoon. It's just a little bit after 2:30 Central Time. My name is Adele Perry, and I want to welcome you all to the Center for Human Rights Research Critical Conversation Series. We come to you from Treaty 1. I am not far away from the Red River, where the geese have really returned and where we have a particular stage of winter. And I am always honored to be here as a guest in Treaty 1 territories, the territories of the Anishinaabe, Innu, and Métis people, governed by the promises, most of them unfulfilled, of both Treaty 1 and the Manitoba Act. For a long time, this series for the Center for Human Rights Research provided a way to combine a senior and graduate level course and a wider sort of seminar open to the public. This year we've been online, and our focus has been on how historians and other folks who are interested in the past and the present and their complicated relationships to each other have addressed, or more often maybe failed to address, a wide range of historical events and processes that we might consider under the really broad tent of human rights violations or atrocities. Within the context of Canada and the territories, both Indigenous and colonial, that preceded it. How have scholars, researchers, and public history folks addressed a historical record and present that includes, amongst other things, slavery, dispossession, incarceration and internment, forced removal, segregation, and expulsion in places, including institutions that Canadians hold dear, like healthcare? How have languages of human rights that have circulated so widely since the post-war era either helped or not helped to understand and engage these histories? What are the limits and possibilities of the framework of human rights and also of Indigenous rights for understanding and accounting for these difficult histories in the context of Canada? Today, we are honored to be joined by not one, but two historians, Lindsay and Erin, both of them with the Manitoba Indigenous Tuberculosis History Project based at the University of Winnipeg and led by Dr. Mary Jane Logan McCallum. Dr. Millions has a master's from the University of Saskatchewan and a PhD from the University of Manitoba, where her dissertation won the Canadian Studies Network for the best dissertation of the year. She is a research director at the Manitoba Indigenous Tuberculosis Histories Project, which I cannot come up with a good, easy to say acronym, but I'm working on it. And she also sits as a member of the Welcoming Winnipeg Committee. Dr. Lindsay has a master's in history with a focus on archival studies from the University of Manitoba and a PhD in history, also from the University of Manitoba. And those of you who are in the class associated with the seminar series learn some about that research in the article you read with her that Dr. Lindsay co-authored with Dr. Negon Sinclair and Dr. Carlisa Posnick. She has worked as an archivist and administrator and a research wizard in a number of contexts, including as the archivist for the National Center for Truth and Reconciliation. And Anne is a postdoctoral fellow with the project. And today, Drs. Millions and Lindsay will be speaking about their ongoing work as part of the Manitoba Indigenous Tuberculosis History Project. This is critical, emergent research on a historical, and I would also argue in important ways, present day historical wrong that is really kind of, I think, coming into a new focus, and in part because of the critical work that Drs. Lindsay and Millions are doing with Dr. McCallum. And this speaks very directly to the concerns of our series and our course, and we are enormously grateful to them for making the time to join us here today. So with that, I will turn things over first to Dr. Millions.
Thanks for that, Adele, and thank you for inviting us. I'm just going to work on sharing my screen here while I chat. I'm excited to be here today, and also because I think that, as happens for a lot of researchers on areas that are human rights related, there we go. There we go. There's a lot of things that you feel feelings about your work and about the people you talk to and what they have gone through. But this talk has given me a chance to think through what I feel about these histories and the ways we're researching them in ways that are a little bit more analytical. I don't know why this won't work. All right, well, I was gonna try to see you all while I talk, but it's not working, so. There we go, okay, apologies. Here we go. To think about these, the things I've been thinking about around records access to doing these histories that we are working on. So Dr. Lindsay is going to present a case study of what she has learned about individuals from the research that we've been working on, and a little bit about how that research is done in relation to the records. And I'm going to talk about some of the challenges that we deal with doing this research, and particularly in relation to access restrictions to historical records related to health, death, and burial. Just setting a timer for myself here. There we go. So leading up to this talk, I've been thinking about, you know, what do I think about the work that we're doing? And I think that what I feel strongly about what we're doing with relationship to histories of Indigenous tuberculosis, histories of Indigenous health in Manitoba, was that Indigenous communities, former patients of the Indian hospitals and TB care centers, their families, have a right to know these histories, and they have a right to access the documents that tell the sort of written in the document side of the story. So I do not at all claim to be an expert on UNDRIP or the call to action or the Joynet or rent liquor principles here. But I was poking around a bit to see sort of where does this they should know sit in relation to human rights and Indigenous rights. And what I came up with was this right to know. The right to know is framed in the UN Joynet or rent liquor principles, which are a reaction to human rights violations. Like, so how do we deal with the aftermath of human rights violations? What are the rights and what are the processes? We also have the United Nations Declaration on the Rights of Indigenous Peoples. It actually doesn't talk much about history in relation to colonial history in reading it, although again, I'm not an expert. It talks a lot about traditional knowledge, language, rights to continue knowing traditional histories, but not much about rights to access past histories as they are documented in the archive. And then that brings us to the Truth and Reconciliation Commission calls to action, and call to action number 69 calls upon Library and Archives Canada to adopt and implement these UN documents and principles as related to Aboriginal people's inalienable right to know the truth about what happened and why. Now, this is in relation to residential schools, and as you're going to hear from Anne, the story of residential and Indigenous tuberculosis care in the mid-20th century is so closely connected that we can't really pick them apart if we want to understand fully what's happened. So I just want you to think about this right to know as I go through, and we'll come back to it a little bit in the end. And spoiler alert, I don't have answers to the questions I'm posing here. They're just things that I've been thinking about as well. So I'm a historian of Indigenous histories. I'm not a specialist on human rights or even on Indigenous rights. What I am is a researcher doing work in collaboration and in support of Indigenous communities, and a researcher who's constantly navigating the barriers put in place by the state to access the records about these histories. And these laws are put in place and interpreted and implemented in a variety of different ways in different places, ostensibly to protect private and personal information. So privacy legislation may protect the privacy of individuals, but the laws also protect the state from an Indigenous control of Indigenous records, from close inspection of the treatment of Indigenous patients in the healthcare system at a close and personal level, which is really applicable today equally as it was in the 1930s to the 1970s, which is the period we're studying. And from bringing the various levels of the Canadian state into account for the often segregated, often substandard, and often coercive healthcare system for Indigenous peoples in the mid-20th century. These privacy legislation serve as a barrier to truth, as a barrier to the right to know, and as a barrier to, as you know, the R word in Canada, reconciliation, as related to histories of Indigenous tuberculosis in healthcare. So I'm going to talk just briefly, give an overview about our project, and then I'll talk a little bit about Indigenous tuberculosis history, and then I'll come back again and talk about sort of the records we use and some of the challenges in accessing them. So when I ask one of my classes, I primarily teach Indigenous history classes, what comes to mind when I say the word segregated? Most often the replies are related to Black history in the United States, to slavery, to the American Civil Rights Movement. Rarely ever do students connect that word to Indian residential schools or Indian hospitals in Canada. Indian hospitals being a federally funded system of segregated healthcare centers across Canada. Hey, sorry, my dogs are having a spat apparently. So of course in Canada, we have our own histories of slavery and segregation in relation to Black Canadians. But segregation also characterizes many aspects of the policies that shaped Indigenous state relations for over a century. So our project is a multi-year Indigenous health history project that explores the experiences of First Nations, Métis, and Inuit people who were treated for TB in Manitoba between the 1930s and the 1970s. Community engagement and community accessibility are at the heart of our project. A lot of academic projects tend to be focused on, we call them outputs, so journal articles, books, things like that, that are not necessarily aimed at the Indigenous communities they are working at. It's getting better, it's still not great. Our goal is not those sorts of outputs. Our goal is to follow the cues from community. So those are former Indigenous tuberculosis patients, their families, and their communities, as well as the Indigenous stakeholder organizations that we work with, to follow their lead in the research that we do and how we do it. But our other goal is to facilitate access to those histories for these same partners. We do this through gathering, sharing, and building collaborative historical knowledge around things like archival photographs, like you see in this picture, of Indigenous patients and staff from the hospitals, by advocating for Indigenous access to Indigenous historical records, by exposing the hidden history of Manitoba TB sanatoriums and racially segregated Indian hospitals, and by learning about the hospitals from former Indigenous tuberculosis staff and patients themselves. We share this information back to communities that we work with and families in non-COVID times through community workshops, but also through public presentations, social media, and our soon to launch website, which should go live in April, which will host both our searchable photo database of historical photos that we've gathered from archives across the country from the Manitoba tuberculosis hospitals, and as Anne will be talking about soon, her online research guide for supporting families looking for the burial sites of missing TB patients. Our team does in-depth archival and oral history research to better understand the policies that directed TB care for First Nations, Métis, and Inuit in mid-20th century Manitoba hospitals. So our team leader is Dr. Mary Jane Logan McCallan, as Adele mentioned, who is a First Nations historian, and her interests tend to be primarily in Indian policy as developed by the Department of Indian Affairs and other related institutions, whereas my focus tends to be more on families and children and the experiences of those patients in the hospitals. And then Anne brings her expertise in records and residential schools to our team. So we all sort of complement each other, but with different interests in what's happening. We also use oral histories to contextualize individuals' experiences as patients or as the relatives of patients. Right now, we do have somewhat pressing time issue with this research. Most of the patients who are still alive today were children when they were in the hospital. The oldest one I've spoken to was 15 when they were a patient, and most of them quite a bit younger. So it is somewhat limiting to the community perspectives that we can still access because the perspectives of children in a hospital as patients are going to be different than the perspectives of adults. But we also talked to a lot of children of patients. So their mom was a patient, or an older sibling was a patient. So this is the children's ward of the St. Boniface Sanatorium. It's now St. Amant Center in South St. Vital in Winnipeg. So Indigenous TB care from the 1930s to the 1970s in Manitoba took place in various different care centers, and this included municipal hospitals, provincially funded care centers like the St. Boniface Sanatorium. It was run by the Garry Nuns. It was partly funded by the province, and the federally funded segregated Indian hospitals. That's the historical term, which in Manitoba were the Dinaver Indian Hospital, the Clearwater Lake Indian Hospital, and the Brandon Indian Sanatorium. There were also a few other directly federally administered hospitals in the province, but they are somewhat outside the scope of our project at the moment. All of the other sanatoriums and Indian hospitals in the province, except for the Grey Nuns at St. Boniface, were run by the Sanatorium Board of Manitoba. So Maureen Lux has written about the segregated Indian hospital system in her 2015 book, Separate Beds. So these hospitals were founded in the late 1930s, expanded rapidly in the 1940s and 1950s, and then sort of started winding up in the 1960s as tuberculosis treatments shifted. Like residential schools, Indian hospitals were underfunded, understaffed, provided subpar medical treatment, and kept Indigenous patients separated from their families and communities for much longer than non-Indigenous patients. So patients were often there for years and years. Patients could be and were removed forcibly under the Indian Act and retained forcibly in hospitals, sometimes in jail cells like the cell at the Charles Campbell Indian Hospital in Edmonton, or in locked wards or patient rooms in the hospitals if they tried to run away or suspected they might run away. We're not really sure of the conditions at the municipal hospitals and at places like Ninette and the St. Boniface Sanatorium, in part because of this access to records issues. Those records in Manitoba are restricted. So the federal government wasn't the only level of government involved in Indigenous tuberculosis care. Both the Manitoba Sanatorium at Ninette and the St. Boniface San, as I already mentioned, were partially provincially funded. And as Dr. Lindsay is increasingly finding in her research, there were significant connections between residential school students and municipal hospitals as well, both before and after the opening of the segregated healthcare system in the late 30s, and accelerated in the 40s. So the point here is that all levels of government are complicit. They are complicit in the residential school system because all levels of government here are providing medical care to residential school students in systems outside of the residential schools themselves. And at the very least, the provincial government is also complicit in the removal and treatment of Indigenous peoples from their communities, to especially St. Boniface and Ninette, which were the two largest sanatoriums in the province, under the auspices of the Indian Act, and just in general federal Indian policy. What's become clear to our team as we interact with former patients and the families of former patients, with various levels of government, with archivists, with Indigenous stakeholder organizations, is the extent to which the colonial archive, which we sort of refer to that as records that about, often in relation to what we're talking, records about Indigenous peoples that were sometimes created by Indigenous peoples, sometimes created by non-Indigenous peoples, but they are held as a group in an institution that is controlled by the state or by settler archivists. Access is barred to these records in a variety of formal and informal ways, and particularly to the historical health records essential to our research. Now, this isn't an issue that is specific to our project. This is a much broader issue that includes everything from Indigenous artifacts in museums to the human remains housed at the University of Manitoba or University of Winnipeg Anthropological Museum to sacred sites on the land. So this is a much bigger issue. But the reason that I've outlined how all three levels of government are implicated in Indigenous tuberculosis healthcare in this period, because it means that in order to fully understand these histories, we need access to healthcare records that are held by federal, provincial, and municipal governments and by churches and religious orders. These historical health records, which can vary from everything from historical or hospital financial statements to individual patient files to correspondence, are protected at various levels by privacy laws and personal health information laws. And they vary widely from province to province and from federal level to provincial level. The federal restrictions are actually some of the least restrictive. Records can be released 20 years after an individual's death. In Manitoba, the same record never becomes publicly available. Our health records in Manitoba under the Personal Health Information Act are restricted forever, making them virtually inaccessible to researchers in particular. You can go through a very long and complex application process to get access, but even if you get access, you can't use identifiers like names and locations, which is really what we need to use. Individuals can apply for access to their own records, or sometimes a family member can apply for access to their own records, but there is no process in place, for example, for a First Nation community to apply for access to all of the records related to their own community. Non-health related records like vital statistics records come even under different levels of restrictions again, and different times depending on the province. So the records that we work with that are related to health, that are related to burials, are complex, varied, and specific to local situations. None of the Indian hospitals in Manitoba, Dinniver, Brandon, or Clearwater near the Pas, or Ninette, or St. Boniface had cemeteries on site that have yet to be located or documented in the records. We don't think they're there. But instead, patients were buried in municipal or faith cemeteries. And exactly where patients were buried differs from hospital to hospital. It differs over time. It differs by faith. So it is a very complex process to research this that requires accessing records at various different sites and archives. So when we go to, say, a funeral home and we say, can you show us your records? People are often wary to share information with us. They are in general aware of privacy laws, but don't necessarily know specifically how they work. And it takes a lot of relationship building with faith organizations, with municipal governments. So like, you know, the assistant at an RM who answers the phone also is control of the burial records from the cemetery. And it takes time and patience to do this work. That said, we're very lucky to have a group of activist archivists in various organizations who support our work, and they do their best to interpret privacy legislation to allow for access, which seems to have been its original intention in the 1980s, rather than barring access. We're also assisted by municipal employees, church admin staff, local volunteers, and families, but the support of individuals is not sufficient to ensure the right to know about residential school children treated at TB care centers or Indigenous health histories in mid-20th century Manitoba in general. Ensuring the right to know as it relates to state assimilationist project in Canada is, of course, a vast project that would require many, many changes and many, many different levels of government, but changes to privacy laws that would allow former patients, their families, and their communities unfettered access to historical Indigenous health records is a small start. And here I come back to the call to action 69, to the joint or rent liquor principles and UNDRIP that sort of enshrine this right to know. And how do we make that happen for Indigenous history in Canada in general? But in our case, specifically for historical health records. I'll leave it there.
Thank you. So we'll turn things over to Lindsay.
Okay, well, thank you, Erin. That's a really good sort of setup for what I'm going to talk about, which, like, as you mentioned, is about the more specific, how this looks when we start talking about individuals. So if you've had the chance to read the Three Sisters article on the At the Forks website, you'll probably already have noticed the networks of connections between residential schools, tuberculosis, and Indian hospitals and sanatoriums that began in the 1940s in Manitoba. All three of the Osborne sisters mentioned in that article died in the 1940s in hospitals where they had been sent after attending a residential school, while their family was left to try to find out what had happened to them and where they were buried. So if we could go to the next slide. This path between residential school and often distant Indian hospitals and sanatoriums was a path that became increasingly common after December of 1939, when the Government of Canada took over responsibility for the Dinniver Indian Hospital from the Anglican Church, contracting its operation out to the Sanatoria Manitoba. Like the deaths of the three sisters, the deaths of other residential school students, including Cross Lake students at Indian hospitals and Sanatoria in the 1940s, illustrate both how significantly interconnected the residential schools and Indian hospital and sanatoria systems were, and how imbricated their histories became during the middle of the 20th century. They also illustrate the challenges these interconnections continue to create for families and researchers looking for missing residential school students, as well as sanatorium patients. So the next slide, please. In 2008, Paul Hackett published a case study of the deaths of 4 young Indigenous girls who were pupils at the St. Joseph's Residential School at Cross Lake, Manitoba in the early 1940s. In this article, Hackett argues that the deaths of these pupils demonstrate a number of trends in Indigenous health and healthcare in residential schools in Western Canada at the time, including, he writes, the inability of the federal government and the churches to protect the children who attended residential schools from tuberculosis, even after acknowledging the problem for at least a half a century. The broader conflict between the medical personnel who were tasked with fighting the disease and the agents of the church who sought to run the schools as economically as possible, and the differences in health services provided by the federal government to different parts of Western Canada based on relative location and access to limited resources. The death of one of the children Hackett studies, Mary D., and the death of a number of other students from the St. Joseph's Cross Lake School, whose lives and deaths we'll touch on today, also speak to the importance of understanding the interconnections between Indigenous health and education systems in our approaches to locating the final resting places of residential school students and sanitary patients in Canada. By now, it's well known that tuberculosis was a significant cause of illness and death at residential schools. Factors such as overwork, poor diet, overcrowding, and inadequate medical supervision and care converged in residential schools, placing students at risk of contracting or expressing the disease. At the Cross Lake Residential School, this meant that, as Hackett notes, 7 pupils died in a little over a year between May 1942 and June 1943. 4 of these students' deaths, more than half the total number, were from tuberculosis. 3 of these 4 students would pass away at the school, but a 4th, Mary D., would die at Norway House Indian Hospital. Her death is illustrative of the beginning of a change in how Canada approached the care of Indigenous tuberculosis patients, including those of residential school students. Beginning in 1937, on the heels of a joint federal-provincial TB conference, Canada allocated additional money to tuberculosis case finding and treatment for Indigenous populations. In 1938, the federal government began authorizing sanatorium treatment for increasing numbers of people they framed as Manitoba Indians. The money, $2.50 per patient day, was to be spent on treatment in provincial facilities. In 1939, Canada took over the Diniver Indian Hospital near Selkirk, formerly run by the Anglican Church, and placed the facility's operation in the hands of the Sanatorium Board of Manitoba. This 50-bed facility would be followed by a 20-bed hospital and sanatorium at Fisher River. The locations of both of these hospitals, argues Hackett, continued a pattern of focusing tuberculosis care in regions where tuberculosis was presented as a threat to non-Indigenous populations, regions that were far from residential schools at places like Cross Lake. And we'll go on to the next slide here. Initially, this uneven access to tuberculosis care took its toll on the students who passed away at St. Joseph's without receiving any hospital care. But it had another impact as well, an impact that we're still dealing with today when we search for the graves of missing residential school and sanatorium patients, residential school students and sanatorium patients. While at the school, the fourth child who died, Mary D, died at the Norway House Indian Hospital. Following her death, she was buried in the Catholic cemetery at Norway House, Manitoba, some distance from Cross Lake. This pattern of residential school students being sent to hospitals and sanatoriums would increase in the coming years. While in 1943, the year that Mary D passed away, there were approximately 100 tuberculosis beds available to Indigenous patients in Manitoba. In 1945, that number increased by an additional 75 beds. When Canada converted an American military base near the Pas into the Clearwater Lake Indian Hospital, once again contracting with the Sanatorium Board for its operation there. It was at the Clearwater Lake Indian Hospital that Betsy Osborne, who you've read about, died in 1946 and was buried nearby in the Pas. In 1947, the number of available beds increased again when Canada opened the Brandon Sanatorium, also under the administration of the Sanatorium Board. There, 2 more pupils from Cross Lake School, Nora Jane R. and Etienne F., died in 1948 and 1949, respectively. They're both buried in the Brandon Municipal Cemetery. In 1933, just slightly over 10% of Indigenous TB deaths occurred in a facility of some sort. By 1948, almost half of those deaths were occurring in a sanatorium, notes Hackett. For anyone searching for where IRS students may be buried, this trend alone is worth noting, as it is a reminder of the increasing numbers of pupils who, in light of federal government policy surrounding burials, would have most often been buried near the hospitals or sanatoriums where they passed away, and not near or at the school they had attended. We'll go on to the next slide. Canada's policy and practice surrounding Indigenous deaths at Indian hospitals and sanatoria was no different than its policy and practice relating to the deaths of First Nations and Inuit people in any other context. This policy emphasized that the government would only pay for the funeral and burial of an Indigenous person if their family or band were not able to do so, and then would only pay an amount equal to or less than the municipal or provincial rate for the burial of an indigent person in the place where the Indigenous person had passed away. If Canada was covering the cost of burial, the person's remains would only be returned to their home community for interment if doing so cost less than burial near the place of death. Although some families were able to pay for the burial of a loved one, or even for the transportation of the remains home, they could only do this if they were aware of the person's death in time to make these arrangements. But when a patient at an Indian hospital or sanatorium in Manitoba passed away, often far from home, many families and communities did not have this opportunity. Families already separated from their loved one might not hear of their death or might not hear of it in time to make burial arrangements. Other families did not have the resources to pay for the transportation of the patient's remains and their burial. Under this system, many patients remained both separated and segregated even after burial. Patients who died at Indian hospitals and sanatoria and whose remains were not returned home were often buried in dedicated sections of local cemeteries set aside specifically for Indigenous deaths or deaths at these facilities. The administration of the records of these cemeteries could fall to religious entities, to businesses, to municipal or federal governments, or to some combination of these. Today, the existing records for these cemeteries range from detailed to missing. In these cemeteries, graves might go unmarked or could be marked by inexpensive and potentially transitive means. In the 1950s, when a grieving mother wanted to mark her child's grave, located in a section of the cemetery on the Sioux Valley Reserve set aside for the burial of patients from the Brandon Sanatorium, the Indian agent expressed concern that a marker might detract from the existing plan of marking the graves with white crosses made out of wooden 2x4s. The agent did, however, allow that the mother might have a plaque made that could be fitted onto the cross's arms. At the time of writing, not all of these wooden crosses remain. A single stone marker stands out in the section of the Brandon Municipal Cemetery set aside for Brandon Sanatorium patients who died between the opening of the facility and early 1950, when it appears burials shifted to this section of the cemetery on the Sioux Valley Reserve. A small pillow marker and a wooden cross are the only other monuments in this section of burials. Anglican patients who died at the Denver Indian Hospital might be buried in a separate section of the cemetery at the nearby St. Peter's Denver Church, where today a single marker keeps watch. And while there's a plan for the Denver Cemetery, if there had been detailed plans for many of these other cemeteries and cemetery sections, they can be difficult to locate. Near Clearwater Lake Indian Hospital, patients were buried in separate sections of the local Riverside and Lakeside cemeteries, and in a separate cemetery at what is known as Mile 6 Big Eddy, a location identified by its position along the rail line. For the Osborne family, their research ended with an unmarked grave in a section of a cemetery in the PA reserved for Indigenous hospital patients. We'll go on to the next slide. The fact that so many Cross Lake residential school students passed away not at the school, but in an Indian hospital or sanatorium in the 1940s was not accidental. As Maureen Lux writes about the beds set aside at the Coppell Indian Hospital in the 1930s for Indigenous patients, Canada preferred to send patients for hospital care based on social, not necessarily medical criteria. This included young residential school students whose families demonstrated progress along the path to assimilation, writes Lux. Generally, sanatorium directors preferred to admit those whose disease was not too far advanced, those who stood a chance of recovery, Lux states. In this context, the ease of surveillance and control of Indigenous students at residential schools only added to the increasing likelihood that residential school students would be transferred to a hospital if they fell seriously ill in Manitoba in the years after 1940. This trend, seen with the hospitalization and death of Mary D. in 1943, is evident in the histories of the lives and deaths of other students at the Cross Lake Residential School as well. Next slide. Mary D. entered the Cross Lake School in September of 1941. By 1942, she was so ill that she was absent from classes for the entire second quarter of the year and was discharged that September, returning again in December. In 1943, she contracted influenza during the first quarter of the year. Then in May, she fell so ill that the doctor put her on bed rest until she could be sent by canoe from the school to the Norway House Indian Hospital on the 2nd of June. There she passed away from tubercular meningitis a little over a week later. Mary D. is buried in the Roman Catholic Cemetery at Norway House. Next slide. As you've read, Betsy Osborne entered the Cross Lake School in 1939 and was discharged in 1946 with the notation that she had been sent to sanatorium. She passed away at the Clearwater Lake Indian Hospital near the PA in May of that year and was buried in the Riverside Roman Catholic Cemetery in the PA. It would be decades before her family would be able to find out where she was buried. And our next slide. Two other Cross Lake students, David M. and Colin M., would die at Norway House as well. David M. entered the Cross Lake Residential School in 1939. Colin M. entered the school in September of 1941. Colin M. passed away at Norway House in 1943, David M. in 1947, 8 days after he had left the Cross Lake School for the hospital. He's buried in the Norway House Roman Catholic Cemetery, and we're still looking into where Colin M. is buried. Two more students, Nora Jane R. and Ed Chan F., were also sent from the Cross Lake Residential School to the Norway House Indian Hospital in 1943 at the insistence of the school's doctor. We don't know at this point what happened to these two students after they were sent to Norway House, but by the late 1940s, both of them were buried in a section of the Brandon Municipal Cemetery that includes a significant number of burials of Indigenous patients who died at the Brandon Sanatorium. This section of the cemetery has almost no markers, as we've already discussed, but fortunately, the Brandon Municipal Cemetery has kept records of these burials and today provides an interactive burial search and map that allows family members to locate the graves of their loved ones. Unfortunately, it's not likely that family members who might be searching for the graves of these two students would start by checking a municipal cemetery in Brandon for a child who'd been sent to a residential school in Cross Lake. Next slide, please. If, as Hackett notes, the young Cross Lake students who died at the school were not only victims of tuberculosis, they were also victims of their times and of where they lived. Beginning in the 1940s, as institutional care for ailing residential school students became increasingly common, the students, their families, and their communities also became victims of a system that moved them from their schools to distant facilities strategically positioned to protect non-Indigenous populations from the perceived threat of Indigenous tuberculosis, locations that were often quite distant from residential schools and communities in northern Manitoba. In the next slide. This, combined with poor or no communication with families following patient deaths, burial policies that emphasized economy over humanity, complicated and often spotty records keeping, and the wide range of places that records could be created and retained, have left families searching for loved ones who went away to a residential school and never returned with what is at times an impossible task. Through its ongoing research and advocacy, the Manitoba Indigenous Histories of Tuberculosis Project is working to help families find the resting places of their loved ones, including the residential school students who traveled from the school to hospital or sanatorium and never returned home. And that's the end of that.
Well, I want to thank you. I want to thank you both for your